So doing some bone grafting might be a necessary step before we're going to do an implant. And the reason is when we have a tooth that's present, the bone that's present there is simply a result of the tooth being there. So if we take out a tooth, the bone that used to support that tooth is no longer needed and it begins to melt away. And so it starts to get narrow first and then it loses height. And so one of the ways that we can avoid that is when a tooth comes out that day, we can take some bone graft material that comes from a jar. It doesn't necessarily come from the patient at all, so that's a great thing, so it's painless. So we open up the jar and we put in the bone graft material and we'll kind of pack that in. And what that does is it provides a scaffold, a little scaffold for the patient's cells to, or bone cells to crawl across and deposit new bone. And so that maintains the dimensions that we have there. So I tell them it provides some dimensional stability so we don't lose the height and width that we need in order to place an implant. So it's incredible how it's changed dentistry. By putting in that bone graft is a very substantial improvement, because we'll see patients who have had a tooth out elsewhere, and they'll come in and you can just see the ridges collapse. And if we had simply put in some bone graft material to avoid that collapse, that would have really been beneficial. And so in the end, when we have not placed a bone graft and that ridge is very narrow, then what I need to do is I need to build out the width or build back the height. And there's certain techniques that we need to do in order to build back height and width, which are much more advanced, require additional training, and something that I am passionate about, that I really like to do. So I'm happy to do that, but I really would love if when we take out a tooth, we put into bone graft to obviate the need for it. If a patient needs a bone graft, does that mean that it's too complex for most surgeons? I think it really just depends on the patient's, or rather the surgeon's experience. So if a surgeon has training where I think that you have to kind of go and see some of the experts around the world. And so if we see that a surgeon has gone and done this additional hands-on training, you can do that in anywhere, but a lot of times it'll take you to different places in the United States or in Europe or in South America, where you're going to see some of the experts and work with the materials, work with your hands, and work with them guiding you. And it's just something that lends itself to becoming capable of doing this back at home. So I think that it is complex for some oral surgeons or for some periodontists, simply because they don't have the experience or the teaching that is necessary to do a really great job with it. Some of the advancements that have been made in bone grafting techniques and materials include using allograft materials. So allo means other, and graft is the bone graft material. And so what we're using are other donors' materials. So we can use cadaveric bone or cadaver bone, and instead of harvesting from a patient's jaw or from their hip or from their skull, we can, which are complex surgeries that you have to go to the hospital for, we can simply open a jar. And by opening up a jar and getting some of those materials, we know that they're proven to be effective, they're proven to be safe, they're screened, so there's nothing in those materials other than the inorganic components of calcium and phosphate, which are the parts of bone that are needed to kind of form a scaffold. So everything organic that you could react to is removed and tested for to ensure that it's safe, and we use the safest products. So that's one huge advancement that allowed us to start doing these procedures in an in-office setting versus in the hospital setting. And that's made a significant difference in terms of morbidity too, meaning that we don't have to harvest from a different site and place the bone graft at a second site. And so by only having one surgical site, we kind of cut down in half the amount of discomfort that somebody might have. The other things that we've used are something called platelet-rich fibrin, or PRF. Platelet-rich fibrin is wonderful in that we can use the blood, and within the blood there are platelets, and we spin down the platelets in a centrifuge to break them open to get growth factors out. We concentrate those growth factors and we'll mix it with the bone graft material that we're going to use, and that's called sticky bone. and it makes bone nice and sticky so that I can hold it together, and it releases growth factors over a period of weeks, and it helps to have the soft tissue heal over the top, keep the area nice and healthy, especially if it has some white blood cells, helps avoid infection, and helps the area to heal better. So those are two significant advances that have made a world of difference in terms of membranes and tacks and screws, and there's all kinds of little things that aren't as readily noticeable, I think, to a patient, but these are two aspects that make a huge difference to patients in terms of their healing, in terms of how much more comfort they'll have versus going to the operating room like we used to when I first started doing this. Really very helpful. I think having a medical degree in addition to a dental degree really puts me in a position where I'm typically not going to see something that I haven't seen before. And so I think that the training that a 4-year oral surgeon has, which is outside of medical school, they certainly go through some rotations in medicine and surgery, but I think to have the medical degree, you have to go through all of the rotations in medicine and surgery, and it just creates a landscape over a couple of years to 3 years or 4 years, whatever is required of the medical school. So that provides a landscape whereby you're going to see things that you probably will never see again, but you get to see how people think. You get to work with, I went to University of Michigan, so I get to work with world-renowned surgeons, seeing how they think, seeing the techniques that they use. And so I take that experience and I make it my own experience, and I bring that to the office. And I think that's really been something where I became more comfortable that, okay, there's not going to be anything that I really haven't seen before, and there's probably not going to be something that I can't think through based on all of the different rotations that we've done in transplant surgery and OB-GYN delivering babies to hematology oncology. And so with our aging population, having a good background in oncology or having a good surgical background in many facets, when patients come in, they may not be very healthy, but there's unlikely a chance that they've had some sort of procedure or a surgery or a condition that I haven't heard of. Coming from a large teaching hospital at University of Michigan allowed me to really see a lot of things that made a huge difference in my development and how I see patients and treat patients.